Hey everyone, let's talk about vertigo. A patient comes in saying the room is spinning. But remember, vertigo isn't a diagnosis, it's a symptom. Our job as clinicians is to figure out the real problem. Is it coming from the inner ear, or is it something more serious happening in the brain? This is the core of our differential, peripheral versus central causes. To sort this out, we'll use a powerful tool called the HINTS exam, along with the timing of the vertigo. First up, let's look at peripheral causes, which are far more common. The big one is BPPV, or benign paroxysmal positional vertigo. This is when tiny crystals, or canaliths, get dislodged in the posterior semicircular canal. The key clue here is very brief episodes of vertigo, lasting less than a minute, that are always triggered by specific head movements, like rolling over in bed. There's no hearing loss. Next is Meniere's disease. This is caused by excess fluid pressure or endolymphatic hydrops in the inner ear. Think of the classic Triad, episodes of vertigo that last for hours. Fluctuating hearing loss and tinnitus, or a feeling of fullness in the ear. Then we have vestibular neuritis and labyrinthitis. Both are usually caused by post-viral inflammation. The main difference, vestibular neuritis, is vertigo alone, because it only affects the vestibular nerve. If the patient also has hearing loss, it's called labyrinthitis because the inflammation has spread to the cochlea. Now, for the central red flags, the ones we can't miss. Vestibular migraine is actually the most common central cause of vertigo. The key is to ask about a history of migraines and look for associated symptoms like sensitivity to light. The most dangerous cause is a posterior circulation stroke, or TIA. Remember the 5 Ds. Dizziness, dysarthria, dysphagia, diplopia, and dysmetria. A critical sign on exam is vertical nystagmus, or nystagmus, that changes direction when the patient looks left or right. This brings us to the HINTS exam, our secret weapon for acute, continuous vertigo. It's actually more sensitive than an early MRI for ruling out a stroke. It has 3 parts: the head impulse test, Nystagmus, and test of Skew. A normal head impulse test is a major red flag for a central cause. Direction-changing nystagmus or a vertical skew deviation on eye alignment also point straight to the brain. Mastering this exam at the bedside can be life-saving. Thanks for watching. If you found this helpful, be sure to like and subscribe for more clinical tutorials.